Hello, everyone. Good morning, good afternoon, good evening, wherever you are joining us from today. I'm just going to give another minute or so for people to file in, and then I will go ahead and introduce today's speaker and topic. Thanks. So it's 9 o'clock here in Calgary, so I'm going to go ahead and start us off for today. So welcome everybody to our next installment of the CHI International Alliance's speaker series. My name is Dr. Jessalyn Holodinsky, for anybody I haven't met before, and I'm a faculty member at the Center for Health Informatics, and I have the privilege of hosting today's webinar. Before I begin, I would like to acknowledge that the University of Calgary, located in the heart of Southern Alberta is located on the traditional territories of the peoples of Treaty 7, which includes the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation within Alberta, including Nose Hill Métis District 5 and Elbow Métis District 6. I'm very pleased to be able to introduce today's speakers, my friend and colleague, Dr. Na Li, who will be speaking on secure medical record sharing innovations in federated learning for health research. Dr. Na Li is an associate professor in biostatistics and health data science in the Department of Community Health Sciences at the University of Calgary, and she's also a valued faculty member here at the Center for Health Informatics. She has a PhD in statistics and postdoctoral work in computing and software, and she specializes in advanced statistical and machine learning methods for health research. Her research focuses on developing secure, explainable AI approaches that transform routine Canadian health data into clinically actionable tools and workflows. Her applied research includes critical care, transfusion medicine, hematology, disease surveillance, and health services and resources. So it's my pleasure to have Dr. Na Li here today to chat with us. The Q&A function is enabled in Teams, so if you have any questions as we go, please feel free to put them in the Q&A, and I will bring them to Dr. Li to address at the end of the presentation.
Thank you very much, Dr. Holodinsky. Good morning, everyone, and thank you for being here. So today's presentation, I will talk about secure medical record sharing and more specifically, how federated machine learning can support health research when we need collaboration across institutions, but cannot simply put sensitive data into one place. The central idea is straightforward. If moving data is difficult, risky, or not permitted, can we instead move the model and still learn effectively across sites? That's the core idea for this presentation. And before I move into the content, I want to briefly disclose my roles and support. I am Na Li, as introduced, Associate Professor in Biostatistics in the Department of Community Health Sciences at the University of Calgary, and a co-founder and Chief Scientific Officer at FedEMR.ai, which is a university-originated zero-code AI platform designed to support sustainable multi-institutional collaboration. And relevant grants and research support include Alberta Innovates, CHR project grants, Sepsis Canada, and NSERC Alliance funding. And this presentation will address 4 questions. First, what are the current challenges in health data access and in integrating AI into health research workflows? Second, what is federated learning and how does it work in comparison with more traditional centralized approaches? Third, how can federated learning support machine learning applications in health research, especially when working with cross-provincial electronic health records? And lastly, what are the major implementation challenges and what are realistic ways to address them? So at a high level, this presentation sits at the intersection of 2 broad challenges. One is health data access, and the other is AI integration. I will begin with a quick overview of the main challenges and categories of health data. So when we talk about health data, we are not talking about one uniform resource. Administrative data are often collected for service delivery, finance, logics, and surveillance. These datasets can be extremely valuable for population level research, but they are usually more structured and smaller in scope than richer digital clinical records. Digital health data include electronic medical records, imaging, clinical notes, laboratory test data, medications, wearables, and genomic data. These are much larger and often much more complex. Clinical trial data and registries are quite different from the other two because they combine clinical detail with management and research structure. So from the beginning, the data ecosystem is heterogeneous, both technically and operationally. And this table highlights the Canadian provincial administrative health data for research. The broad point here is not just that provinces all have health data, but the availability, structure, accessibility, and linkage potential vary in very important ways. There is no single uniform environment for data access. That means multi-jurisdictional research often encounters substantial coordination work before any modeling can even begin. And in Alberta, the digital health data ecosystem is not a single and simple database. It's a network of systems, contributors, repositories, and interfaces. The complexity matters. Data access is a legal issue and also a system issue. Even when the data exists, pulling them out, standardizing them, linking them, and managing them across different platforms can be a really really challenging and a real issue. A simpler uh, there is another similar example in BC. The key message here is that different jurisdictions have different architectures, workflows, and access pathways, as you can see from comparing the Alberta and BC systems. So when we talk about national or multi-provincial learning, we are not working with one shared or standardized technical project with the same data. We are actually working across different systems, different governance regulations, and different operational realities. And at a practical level, four challenges come up repeatedly. The first is distinct data silos. Data are held in different institutions and systems, often without straightforward operations procedures. The second is data privacy. Patient data are sensitive, and the expectations around data stewardship are rightly high. The third is cross-border or cross-jurisdictional data sharing, which is considering additional operational and legal complexity. The last one is regulatory compliance, where institutions must align with multiple policies, approvals, and oversight processes. So these barriers make centralized pooling difficult, even when the scientific question clearly calls for collaboration. And furthermore, AI integration is not automatic. There are technical and regulatory barriers in infrastructure and workflow. Data shift across sites and over time can undermine model performance as well. Performance like transparency and generalizability remain ongoing issues for machine learning models, especially if we want models to perform beyond one local setting. There are also questions around safety, security, trust, and broader public acceptance. So in other words, the AI challenge is not simply training a model, it is developing a system that can be trusted, maintained, and used responsibly. And with these challenges in mind, I want to introduce federated learning. I will cover what federated learning is, how it compares with centralized learning, and how it works at a high level. So federated learning is a distributed machine learning approach that allows multiple parties to collaborate on a modeling task without sharing the underlying sensitive data, such as patient records. Instead of bringing all data into one location, each participating site keeps its data locally and contributes to model development through controlled parameters or update sharing. That shifts, this kind of structure shift sounds simple, but it actually changed the data governance model in a very important way. So in centralized learning model, the usual workflow is to bring the data to the model, as you can see on the left of this slide. The data from different sources are transferred, pooled, and then used in one environment for training and evaluation of the machine learning or deep learning models. In federated learning model, we instead bringing the model into to the data. The model or its updates can move across sites, while the raw data source actually remain into the local site. And this is the essential conceptual shift. It doesn't eliminate all the complexities, but it changes where the most sensitive data actually resides in the local site. It doesn't require any data sharing. It's the only part changing is the model parameters actually change across the sites. And this comparison table highlights why federated learning is attractive in health research. Relative to centralized learning, it is often better aligned with local governance, privacy, and regulatory constraints because institutions do not need to share the patient records into one pooled location. It can also improve access to broader and more diverse data sets. But at the same time, it introduces its own challenges, including coordination, software requirements, and implementation complexity. So the right framing, I think, is not that federated learning is universally superior. The right framing is that it may be a more practical and compliant strategy in settings where data centralization is not feasible. And federated learning can be classified along with two dimensions by data partitioning and by development setting. By data partitioning, we have horizontal federated learning, where sites share similar features but have different patients, and vertical federated learning, where sites have different features for the same patient or overlapping patients. And then by development setting, we have cross-silo federated learning involving a small number of institutions, and cross-device federated learning involving many end-user devices, and can be phones, iPhones, and different devices. And in this presentation, the key setting is horizontal cross-silo federated learning, which is the most relevant model for multi-site health research. The current literature suggests that federated or other decentralized approaches generally perform better than locally trained models, and performance is often similar to centralized learning. However, results still vary by performance metric and application. There is substantial methodological diversity across distributed statistical and federated workflows. These approaches differ in what information is exchanged, how estimates are aggregated, and what the main goal is. For example, is it prediction, coefficient estimation, or statistical inference? And most importantly, federated learning should be viewed as a complementary methodology or tool rather than a replacement for meta-analysis because these two approaches play different roles in decentralized research. And here to explain how federated learning works, I will use the federated version of linear regression as an example. So in step one, centralized a global linear regression model is created with a set of initial weights. These weights could be random or pre-trained based on previous data sets or methodology. In step 2, each participating site maintains its local data locally, and the central server sends the initial model weights to each site. And in step 3, each site then trains the model locally on a subset of its data, adjusting the model weights based on its local data subset. This local training step involves calculating the local model gradients or changes needed for the global model weights based on the local data. And once the local model training is complete, each site sends these gradients back to the central server, and the raw data remains at the local site, ensuring privacy. And in step 4, the central server then aggregates these gradients from all sites to update the global model weights. Aggregation can be a simple average of these model weights, or involve more advanced techniques depending on the specific federated learning algorithm in use or aggregation strategy. And these steps are repeated in multiple runs, and we consider it as federated runs. With each iteration, the global model is improved as it learns from the entire spectrum of the data distributed across the participating sites, all without actual data ever leaving its local environment. Okay, so to summarize here, the federated learning methodology or tool offers a practical framework for working with distributed health data. It supports data management across sites, remains scalable and flexible as an approach, and can be adapted to local privacy requirements. And in many settings, it achieves performance that is close to the centralized learning and sometimes outperform local models. In the next part, I will briefly highlight 3 examples from my research group for multi-site federated learning benchmarking. We are working on the manuscript currently for these projects. We also have ongoing work in areas such as health resource optimization, trajectory analysis, and survival prediction. And I will briefly introduce them. And the first example is sepsis detection. Here, the objective was to detect sepsis among ICU patients and compare federated, local, and centralized learning. As shown on the right of this slide, this study used the linked clinical and administrative data defined for a cohort of adult ICU patients across multiple sites, and used the adult sepsis event definition as the outcome for detection. The prediction task was to build from a relatively rich feature set, including about 101 predictors. So this example gives us a good example of how federated learning performs in a clinically complex setting with high-dimensional predictors. And this diagram summarizes the model training and comparison workflow. We started with structured data distributed across Calgary sites. For the centralized model, data were pulled for model development. For federated model, the data stayed at each site and only model parameters were exchanged across training runs. And for the local model, each site trained only on its own data. And we then evaluate all 3 approaches using the same overall framework. So the performance comparison was as fair and consistent as possible. Again, this example is for critical care considering sepsis detection in ICU patients. In this content, you can see from this table, The first row indicate the federated XGBoost model, and XGBoost model is more like a shallow machine learning model considering boosting trees. And the second row here is considering local XGBoost model only trained with local data. And the third one is considering centralized XGBoost model, considering we can pull all the data together. And here, this table is evaluating the AUC performance on the held-out data set, which were not seen by the model itself when training the model. And we have 4 sites here. And in the actual project, we actually consider more performance metrics than beyond AUC measures. Here, just for presentation purpose, we just reported AUC. And in this content, you can see federated learning maintained competitive overall and came quite close to centralized and the local model based on the AUCs at larger size. The main limitation appear at the smallest site here, where the performance gap became more noticeable. So the key message here is that this example shows that federated learning can work well even in a complex clinical setting, but its performance may be sensitive to sample size for the local size, especially when we have a large number of feature set for this type of prediction task. And the second example focuses on acute myocardial infarction, or AMI, which is considering an acute care setting. So the same table showing here, we have the federated XGBoost model, local model, and centralized XGBoost model. And if you compare with the sepsis study, from this one, you can see this was only considering like a smaller set of variables with less than 10 predictors in the model. And this is a much lower dimensional problem compared to the other one. And in this setting, the federated model actually outperformed both the local and central model in most sites. So the main message here is that federated learning can be particularly effective when the prediction task is driven by a small number of strong predictors that are shared across sites. This is the second example. And then the third example here is for diabetes detection in a chronic care setting. And the same table showing here on this slide. And for this project, we consider the CREATE database, which is linked with the approach dataset with electronic health records considering laboratory tests and medications, and also the administrative data. And here we are considering adult catheterized patients and from 2014 to 2017. And in total, we actually have 49 sites here, but we group them into 3 analytical groups based on their encounter location. So we call them as site A, site B, and site C here. So that we train a model in this framework, considering the federated model across these 3 sites, sharing the model parameters, and the local model trained based on the local grouping of site A, site B, and site C. And then for a centralized model, we put all the data together. And we are also considering more like sensitivity studies by separating those 49 sites, but that's because the sample size for those individual clinical sites could be very small, so that's limiting some strategies in terms of comparisons for federated learning versus local and centralized models. So this is the primary analysis, and we will perform a sensitivity analysis based on smaller sites. And from this table, you can see the federated learning approach was still feasible, and remains competitive when looking at the AUCs. But in this setting, the local model actually performed the best, even compared to the centralized model. So my interpretation here is that this task likely involves stronger site-specific structure. In this case, it's actually site grouping structure. It really depends on how we actually group those 49 sites into the 3 categories. So the sensitivity analysis will really help to answer this question. And the main message to summarize here, as you can see, is federated learning is a practical option, but the relative benefits still depends on the underlying data structure and how much variation exists across those sites. And altogether, these 3 examples suggest a fairly consistent message. Across different clinical prediction tasks, federated learning remained competitive with both local and centralized approaches. At the same time, the results were not identical across these studies. Performance depended on the structure of predictors, the characteristics of the participating sites, and the complexity of the task itself. So the main takeaway, I think here is not that federated learning is always the best performing one. The centralized model is also not the best performing one. Instead, is the a message that federated learning is a practical and reasonable option for multi-site health research when data centralization is difficult or not feasible. And that is also what motivates our ongoing work in additional application areas. And also I should note that here, the results showing here are intermediate results, which are intended to illustrate the main patterns and message. The manuscript we are preparing will present a much more comprehensive evaluation across the 3 clinical tasks, comparing federated, centralized, and local models in a more systematic way. And beyond those 3 examples, we also have several new projects underway that extends this program into different clinical and methodological directions. One area is health resource optimization. And here we are exploring federated learning for immunoglobulin utilization. Immunoglobulin is one type of blood product derived from plasma component in our blood. And with this project, with the goal of supporting evidence-based resource allocation across sites without requiring centralized data pooling. The second area is clinical trajectory analysis. In this line of work, we are looking at federated transformer and large language model architectures for longitudinal patient records, with the aim of modeling disease progression across institutions. And the third one is survival prediction, where we are expanding federated approaches to time to event modeling for chronic conditions in multi-site settings. And the last one is cross-provincial or international deployment. We try to scale our tool on federated learning across provinces and across the jurisdictions for federated collaborations. And in the next part of this talk, I will discuss a practical question. What are the main challenges when implementing federated learning in our projects? What are the lessons we learned and how we address them? And that includes data management, methodological fairness, software frameworks, and deployment realities. The data management challenges can be just as important as modeling challenges. And this is not a challenge unique to federated learning. It's also a problem for centralized learning. One issue is variability in analytical support across sites. if different teams have different levels of expertise or staffing, consistent data preparation and analysis can be very hard. Another issue is technology disparity. Some sites can work with complex tools and some cannot, which increases the effort required for code translation and reproducibility. A third issue is data heterogeneity in collection practice. Even when variables appear similar, differences in how they are measured with different units or different recording strategy can slow our modeling work, especially on data like harmonization and preparation for AI machine learning methods, and can introduce inaccuracies or instability for model performance. So federated learning may reduce the need to share raw data, but it doesn't eliminate the need for strong coordination and data harmonization. And in our federated learning data management efforts, we have achieved some successes. We have processed local datasets in Calgary, Ottawa, and Sherbrooke to facilitate data consolidation and streamline analysis. Our data processing protocol currently developed through programming scripts is undergoing validation and refinement at additional sites in these 3 provinces. Furthermore, we are enhancing our security protocol for federated learning by improving encryption and access controls to safeguard data confidentiality and integrity. To make our system more responsive and adaptive, we have established a feedback loop that allows users to report data issues for continuous improvement. And a more fundamental challenge is fair model benchmarking or model comparison. This is not unique to federated learning as well. In general, model performance can be strongly influenced by data preprocessing choices, data splits, hyperparameter training, and evaluation workflow, whether the model is local, centralized, or federated. What federated learning adds here is another layer of complexity because distributed training introduces communication, coordination, and optimization constraints that make model development harder to standardize. So the key challenge here is not only optimizing federated learning, but comparing all learning paradigms under equally rigorous development workflows. So here we are trying to develop more consistent optimization and evaluation standards across local, centralized, and federated models. And a further challenge is choosing the right federated learning computational framework. And there are multiple open source frameworks, and each with different strengths, capacities, and trade-offs. That means implementation is not just a scientific decision, it's actually related to software and operations decisions. And different teams may prioritize different areas, for example, ease of use, extensibility, monitoring, model support, or compatibility with existing infrastructures. And here I just selected a few. There are actually more tools available these days. And so here, to highlight the challenge, I just compared these 3 frameworks that we actually did some in-depth investigation of these 3 frameworks, considering Flower, NVFLARE, and FATE. And this slide highlights the kinds of trade-offs the teams may face when working with federated learning frameworks. The first one, Flower, is positioned as research-oriented, relatively easy to use and flexible, but with more limited features considering this framework. And the second one is NV-Flare. This is oriented more towards commercialization, like a commercial use, and offers models and dashboard style monitoring. And this one is also more flexible, but may require more time to learn how to use like NV-Flare in depth. And the third one is Fate. This one offers many models and compatibility with larger computational environments. But this one is the hardest across these three to use and to implement because the user guidelines in order to understand how it works is quite challenging to understand. And all these tools require advanced programming and software engineering expertise, and some cannot easily achieve real-world federated learning across jurisdictions. And for many health researchers and analysts, like especially for our healthcare teams, this can create a practical barrier to routine use in clinical practice or research environment. So one of the most important achievement of our work is that we moved beyond federated learning theory and developed a practical implementation platform called FedEMR.ai. And FedEMR is a zero-code federated learning software application that can be deployed across a wide range of environments, including Unix-based systems, Windows, and Mac OS systems. And this is important because one of the biggest barriers, as I mentioned earlier, is to implement adapt federated learning into the local environment. And this is not a methodological problem, it's actually about implementation. And our goal was to make federated learning implementable in real health research settings. So the platform was designed for on-prem deployment with a point-and-click interface that lowers the technical barrier for research teams. It was built for health researchers, trainees, and staff members with an emphasis on inclusivity, like EDI, future-ready architecture, and support for pre-trained, clinically validated machine learning models. And here we are building the infrastructure needed to make federated learning more accessible, scalable, and sustainable in practice. Okay, and the last part I will conclude the key messages. I want to bring the talk back to the original two problem domains, data access and AI integration. So on the data access side, federated learning directly helps with several long-standing barriers. It provides a way to work across distinct data silos, help reduce some privacy concerns associated with central data pooling, supports collaboration where cross-border data sharing is difficult, and aligns better with regulatory constraints because data can now remain under local stewardship and environment. And I would be careful not to say these problems disappear entirely, but they become much more manageable under the right federated design. And AI integration still requires further development. Federated learning helps address the problem of centralized data access, but it doesn't fully resolve broader challenges in health AI integration. That includes fair methodology comparison, hyperparameter optimization in federated settings, better workflow for standardization, stronger framework support, site readiness, and also procedures that make deployment more sustainable. So in summary, federated learning is not the end of the work. It creates a better starting point for responsible federated collaboration. And the main take-home message for this talk is that federated learning offers a scalable and practical pathway for multi-site health research when data centralization is difficult. across the examples I showed today, it achieved competitive and in some settings very strong predictive performance. Although there are some barriers for implementation as well, but it helps address many of the privacy, regulatory, and operational barriers associated with pooling data architecture centrally. And more broadly, I believe federated learning and distributed learning more generally will become increasingly important as health data systems move towards more distributed, locally controlled, and institutionally governed models. It's not a universal solution, but provides a practical direction for future health data strategy landscape. And lastly, I would like to close by acknowledging the study team and collaborators. They are from interdisciplinary team, and the interdisciplinary expertise made this work possible. And I'm very grateful for the broader collaborative network that supported this work. Thank you very much for your attention. I welcome your comments, suggestions, and questions.
Thank you very much, Dr. Lee, for a really interesting and informative talk, and congratulations on this line of research, and then also being able to make your federated learning more accessible through incorporation. So congratulations. I'll remind everybody that the Q&A is open, so please feel free to put your questions in the Q&A, or if anybody would like to ask a live question, you can use the raise hand function. And perhaps while you might be thinking of a question, maybe I'll start off with one. So something I'm a little bit curious about, and maybe you've already done some thinking on this now, is, we have this problem in administrative data and, electronic medical record data for sure. I'm curious about, prospective work. So thinking about clinical trials, do you see a future where maybe, multi-site or multinational clinical trials are also no longer pooling data and using federated methods?
Yeah, so as I mentioned, there are different types of data sets for different type of research projects.
Mm-hmm.
For clinical trials, current strategies are considering collecting all the data first for clinical trials and then do the analysis. I think this workflow will not change in the future, and that's probably the most rigorous way to do clinical trial studies from the biostatistical perspective, because we always need to ensure the data protocol and statistical analysis plan in place at the beginning, and then start to collect data with the blending process for the data analysts, and then proceed the data analysis. And when we move on to the data analysis perspective, considering prospective clinical trials, having this type of federated learning or federated statistical inference tool ready might be able to even help with the blending stage and making the statistical analysis workflow more standardized. And it is possible to run this type of analysis more like regularly with this type of software tool available for the clinical trials. And I think the future, especially with the generative AI tools these days, things can be really simple and user-friendly for future work.
Let's see, I've got a question from Pietro in the chat, so I'll just read it out. So one issue with federated learning as compared to traditional model development is one center and evaluation in others is the selection of the evaluation set. If some participating centers are small, data split for training testing will further reduce the size of the evaluation set. Can synthetic data be a solution? Evaluation sets could be expanded to increase power. What do you think about this?
Yeah, that's a great question. So currently for our projects, especially, I will move on to the third example. Sorry, for the third one for diabetes. So for this one, you can see we are actually grouping 49 sites that consider both acute sites and outpatient clinics into 3 analytical groups. For some of those sites, we have very small sample size. And when we group into these 3 larger site groups, we actually increase the sample size. And this is mainly for the evaluation comparison for the federated learning approach versus local and centralized approaches. The current split we are considering is more like standard machine learning approach using 70% for model training and 15% for validation or hyperparameter training and 15% for held out evaluation. And for some small sites, as you mentioned, it's possible that we cannot do this if we actually split into the individual sites. And I do think simulation based on the synthetic data and performing based on the original, derived based on the original data set will be very helpful. And that process can actually be built into the federated learning workflow. And that is a next step we are trying to evaluate as a comparison for this study by considering the individual 49 sites. So that's I have the result.
So
yeah.
Any other questions for Dr. Lee? Please feel free to use the raise hand or the chat function.
I have a question for the audience.
Absolutely.
Is there a way to raise hand or something? How many of you actually worked with federated learning methodologies before?
Maybe if you could use the raise hand function, then I'll be able to see. Or feel free to just type here in the chat. Yeah.
One. That's good. Oh, great, April. Yeah.
April, do you have a question or comment, or just raising your hand that you've worked with federated learning?
Yeah, this is something I'm really interested to know, and I want to know whether there are resources for learning federated learning outside.
Yeah, same question is coming through in the Q&A as well. How many of you have learned federated learning before? So if anybody wants to maybe add their comment to the chat if you've learned federated learning before. Any other questions, comments, discussion that we'd like to have with Dr. Lee today? Yes, please, Janine.
Hi, Na. I have not received any training or have explored the use of federated learning, but it's a fascinating area to explore when thinking about doing these sort of large scale projects. And you mentioned a little bit about your FedEMR.ai platform. I'm just wondering, because I just went on the website, if you can kind of talk about how individuals like myself or others who might be interested in federated learning or exploring using it, whether we should connect directly with you or go through the FedEMR AI request form. I think there was a form that you can fill out and then get help. So I'm just wondering if that's the best approach for any one of us who might be interested in kind of exploring this idea for potential projects, if that's the best way to connect in with you.
Yes, that's thank you so much for exploring the site. And the best way is to contact us through the website. Or if you already know my contact, feel free to contact me directly. And I have my research manager here. I think Rob is here, right? Yes, Rob Price here.
Yes, I'm here. Yep.
Yeah. Yeah, and Rob is a co-founder of FedEMR.ai, and we are working together to like help spread out the word about FedEMR, and also trying to investigate more effort to learn about federated learning, for the audience. And I think, yeah, in the future, I might consider some materials to introduce federated learning and more detailed methodology on federated machine learning more broadly.
Thanks, Na. That would be
I
great.
think that would be a great, agreeing, Janine. That'd be a great option to have some great educational materials available through you.
Thank you. And this is a very broad area, actually. For federated learning, it's basically a framework. It can work with any type of model, including regression, statistical regression model, machine learning, deep learning, large language models. Any type of framework we can, like a methodology, we can work with federated learning. But there are different challenges for sure for each one. And Pietro, please.
Pietro, please go ahead. No, unfortunately, we can't hear you, Pietro. If you'd like to type your question, I'm happy to read it out. If anybody else has questions or comments, please feel free to chime in. Yes, I see Yuli. Please go ahead.
Hello now. Can you hear me?
Yeah, we can hear
Yeah,
you.
thanks for the presentation. It was really interesting. And I have two questions. And the first one is like when the center server choose the machine learning model, which was the actual boost in your research, like does it share the parameters or like when the model need to be when model do retraining, does it need to do the hyperparameter tunings again?
You mean the hyperparameter optimization for the
Yes.
federated learning process?
Yeah.
Okay, thank you. Yeah, so I think I will move on to the model comparison page. So currently we actually run the federated learning local model and centralized model based on the same set of initial hyperparameters. And there is no hyperparameter twinning during the federated learning process. And the reason is that we want to make a comparison of those approaches first. And the next step is to integrate hyperparameter twinning. Hyperparameter twinning process are more like standardized, well known for centralized and local model training, but there is no standard workflow for hyperparameter twinning for federated learning approach yet. So that's something we want to explore and consider more like a standardized workflow and strategy for hyperparameter training in federated learning.
Okay, yeah, thanks for the answer. And my second question is, like as you mentioned, like pre-processing part is really important for the like health data research. And like I wonder like then when the data is changed, like which part the pre-processing need to be done? Like does it need to be done by like individual researcher or before applying model or middle of the training?
Mm-hmm. So the data extraction and data preparation work currently for most health research projects, as at least the ones I work with, mostly done by local data analysts. For example, in Alberta, data extraction will be done by the AHS team, and data preparation could be done by the AHS team or the data analyst by the individual research PIs. For other provinces, it depends on who we are collaborating with. It's usually done by the data analysts, either by from the PI's team or from the local health environment or systems. And those process, as I mentioned, because of the expertise and skill set, also the tools they are using, they could cause some variations in the preparation steps. And currently we are considering two strategies. One is a standardized data processing protocol. So where we define all the variables with specific definitions and specific variables to transform in order to reach to the standardized data variable to be included in the machine learning model. So that's one way, considering written guidelines for the data processing protocol. The other one is try to create programmed scripts and like packages, for example, R packages for other sites to directly deploy that kind of data processing steps across the sites. And this step can be integrated into the federated learning tool that we are building, like a FedEMR, as well, to help the data preparation and cohort creation step. But this step need to be done individually for each project.
Okay, thank you.
Thank you so much. I know Pietro's put in the chat that you would need some basic education about predictive modeling first to prepare for federated learning. If there's anything you wanted to add to that, Dr. Lee.
Yeah, I agree. And also, this area is so diverse and progressing rapidly. Some education on the fundamental concepts will be important, and also considering the adoption of new methodology in healthcare.
We do have a few more minutes of time with Dr. Lee if anybody else has any final questions or comments. I can also see that Rob has put both his and Na's email in the chat, so you do have access to their contact information to reach out and learn more. Question from Morgan, if the recording will be available. Francis, I do believe we will make this recording available. Is that correct?
Correct. It will be posted on the CHI website page, events. Yeah.
Fantastic. Well, then I will thank everybody for joining us, and thank you so much, Dr. Lee, for your very informative presentation today. And I wish you all a great rest of your Wednesday. Bye now.
Thank you. Bye.